Hi everyone, I'm Jamie. I'm one of the F2s working at Guys. Hopefully I've met some of you before. And thank you for coming along. We're going to be discussing headaches today, but using an A to E systematic approach. And yeah, we'll run through the A&E as we always do, and then talk a bit about headaches, differentials for that, what we need to be thinking about when we go to see a patient with a headache, and then we'll go through some cases. Okay, so as before, so I've just said all that, sorry. So yeah, A to E systematic approach is really good, particularly for acutely unwell patients, and it gives you a strategy to approach any clinical scenario. Really useful, and it helps you to remain calm in a stressful situation, which is very helpful for anyone that's around you. Okay, people really appreciate that. So as before, key principles: be systematic, go through ABCDE. Escalate early. If you're concerned, escalate. If you need to put a peri-arrest call out, if you need to put an arrest call out, you escalate that. That's absolutely fine. And then lastly, focus on your communication with each other, with nurses on the ward, with your seniors. Okay, all really important stuff. Any questions as we go along, just pop them in the chat and I'm more than happy to answer them. Okay, so airway, have a look. Is the airway patent? Are there any airway noises? Is there an obstructed airway? Can you hear like stridor type noises? Can you hear very loud snoring? Can you hear nothing, in which case you might think this patient's not breathing and you've got a cardiac arrest situation? And if there is a problem with the airway, the first thing I would say, get the anaesthetist involved. And then the next thing I'd say is try a maneuver to see if you can open the airway yourself. So a head tilt chin lift or a jaw thrust. And then you can subsequently use adjuncts if you need to be doing other things. So the first, number one there is a Goodell or an oropharyngeal. Number two is a nasopharyngeal that can go in the nose. Number three is an iGel or an LMA, which is a more definitive airway. It's very useful and very easy to put in, actually. And then number four is a endotracheal tube, which I don't think I put a picture of in before, but that's what that looks like. If you can see my mouse on the right hand side of the tube, that's the bit that connects to your to the bag valve or to the ventilator. That's it. And then on the left hand side there, that's a little balloon, a cuff that inflates or deflates as it goes inferior to your vocal cords to keep it in place, which is why it's the most definitive airway and one that prevents aspiration. Okay. Breathing. Look at the patient from the end of the bed. Do they look tachypneic? Do they look blue? Do they look cyanosed? Have they got an increased work of breathing? Are they using their accessory muscles? All really useful signs that takes a bit of experience to gather. But you know, you can tell straight away if someone is in respiratory distress. It's fairly obvious. Look at their observations. So what are their SATs doing? What's their respiratory rate? If you're worried about type 2 respiratory failure and you're aiming SATs of 88 to 92, then you can do that. But ultimately, if someone's hypoxic, very hypoxic, then you need to put them on 15 liters, because hypoxia will kill them quicker than hypercapnia will. Okay, but just have that in the back of your mind that you might need to wean the oxygen down to prevent them going into type 2 respiratory failure, where they sort of are retaining carbon dioxide because they can't blow it off, because that can lead to very detrimental problems such as drowsiness, and they can go into a coma and they can die from type 2 respiratory failure. Okay, examine the patient as well. Obviously auscultate, percuss, look for expansion, and check the position of the trachea, and then get a gas if they're hypoxic, get an arterial sample, and request a chest x-ray. If they're unwell, get a portable rather than them going down, and then treat them, as I said, with oxygen. And you can consider NIV if you're worried about type 2 respiratory failure. You can consider BiPAP. If you don't think 15 liters is enough, you can consider starting them on CPAP. But at that point, you would definitely be escalating to a senior to make that decision. C, so look at them. Are they very pale? Are they very sweaty? Are they clammy? Or are they really cool peripherally? Look at their obs. Are they tachycardic and hypotensive, implying that they're in shock? And then think about the cause of why they're in shock. Look at their cap refill time and their urine output as well, and have a good listen to their heart. And while you're treating anything that you found using cannulas, taking bloods off, and giving them boluses and further fluids, you can ask the nurse to do an ECG, because that's always useful in an emergency environment. D, so as I've said before, I always think there's 4 parts to D for me. It's the first is their consciousness level, so you can use a GCS, and I won't go through it, but you can see the GCS scale here, or you can Google it, or just a simple AVPU. Are they alert, or are they only responsive to voice, to pain, or are they unresponsive? Check the BM. Always check their BM. Have a look at their pupils. Quite important in what we're going to be discussing today, as is GCS, and get a temperature, see if they're febrile, is there an infection on board. And then finally, exposure, and this is sort of depending on what you found in the A to D. So we're trying to work out, so if you've got a surgical patient that's hypotensive, you're thinking more about having a good examination of their abdomen and a PR. If you've got a patient with a headache, thinking more about a neurological examination, and looking for any rashes in particular, okay? And then always just check lines. Have they got a PICC line in? Have they got a porticath? Have they got a central line? All these things can get infected and can cause problems. Then, as always, reassess, very important. Do a more thorough assessment, looking at, a bit more about the background of the patient, their drug chart in particular, and any investigations that they've had done. And think about what further investigations you want to do, as well as the bloods you've sent off, the chest X-ray you've requested, the ECG, the blood gas. Is there anything more there that's more specific tests that you want to do to rule things out, or to get your diagnosis? All right. So I whizzed through that. I hope that was all right. Oh, we've got a few more people joined. Okay, excellent. So we're talking about headaches today. I quite like headaches. It's quite an interesting differential. There's quite a wide range of things that can be going on, and you have to do a little bit of trying to work out what is happening. And in the cases, I've got a couple of stable patients who maybe the A to E isn't so important. Then I've got a couple of unstable patients who the A to E is very, very much important. Okay, and what was I going to say? Yeah, just important to say, headaches are extremely common. I'm sure all of you get headaches from time to time, and on the wards you'll always see patients in hospital with headaches, and more often than not, it's because they're not drinking much, and they're dehydrated because they're in hospital. Okay, but you need to have the differentials in your head, because there are emergencies and there are things that you can't miss. Okay, so first of all, we've got primary headaches. So that encompasses tension headaches, which are sort of stress related, dehydration related. You've got migraines, which are idiopathic, and can be brought on by a number of things. And typically the patient, it can quite often be unilateral. The patient can get nausea. They can also get visual changes. And the patient tends to, it's a really bad headache, can last a couple of days. It typically lasts more than 4 hours. And they often want to go to bed and be in a really dark room. That's quite an important flag for a migraine. And then you've got cluster headaches as well, which are a bit rarer, often in younger people. Again, unilateral, extreme headaches. So whereas a migraine, you sort of want to go to sleep, a cluster headache is like a head banging, like you're in agony. You really cannot get over the pain. And they get autonomic features as well. So you'll get sort of watering of the eye and leaking from the nose, that sort of thing. Rhinorrhea. So those are your 3 primary headaches, and then more sinister things. So subarachnoid, we typically speak about a thunderclap headache. It's a bang. It's caused by a berry aneurysm, typically around the circle of Willis, and you get a sudden bleed, often on exertion. There's multiple causes of subarachnoids. So delving into the history is very helpful, but yeah, typical sudden onset, they get vomiting, they can have seizures, they can be really, really poorly, and they get meningism as well, because you get a buildup of blood under the arachnoid matter, which irritates the meninges. So you get your can sometimes get your cardinal features of headache, neck stiffness, and photophobia. And then stroke typically don't present with a headache, but they can do. Often posterior strokes and basilar strokes can, as well as reduced consciousness, and then classic features of a stroke depending on where the lesion is. And that's delving more into sort of neurology. Trigeminal neuralgia, so that's an inflammation of the trigeminal nerve, which typically presents as a sort of shock type pain, burning pain, really neuropathic pain on one side of the face, radiated along the path of the trigeminal nerve, okay, which obviously feeds, there's three branches, the ophthalmic, maxillary, and mandibular. So that, again, history is important for that. GCA is a rheumatoid condition. It's a giant cell arteritis affecting the temporal artery. You get jaw claudication is a classic sign, so pain on one side of the face on eating. You get scalp tenderness, and typically they'll be associated with other rheumatological conditions such as polymyalgia rheumatica. Venous sinus thrombosis does what it says on the tin. It's the big venous sinus at the front of the brain that drains blood from the front of the brain, can get a thrombus, and this can cause a number of neurological signs, particularly affecting cranial nerves 3 to 6. BIH, below that is the etiology is poorly understood, but you get sort of fairly dull headaches, and it's often associated with obesity, but quite a rare condition, but important to know about. And then obviously malignancy can present with headaches, so just delving into the history and further symptoms is useful for that. Infectious causes, so the big ones, meningitis, encephalitis. Meningitis, think about infection, think about meningism, like we had with subarachnoid hemorrhages, so that's headache, neck stiffness, photophobia. But don't be fooled by these. Often, I think only 50% of patients with meningitis get photophobia. Okay, so you don't have to have the three symptoms. And encephalitis is normally viral, again, can present with headaches. Other systemic infections that you get in other parts of the body, and fevers can just present with headache secondary to dehydration from fluid losses, purely because you're febrile. Sinusitis, inflammation of the sinuses around the nose, can present with a really horrible frontal headache, and ear infections as well tend to be more localized to the ear and the jaw as well. Okay, so I've ran through that, and as I said, there's a wide differential for headaches, and that's why I think it's quite an interesting topic to discuss. So other signs and symptoms to be aware of when you're talking about headaches. So in your history, you do your A to E, obviously, and you'll be guided by how stable the patient is with that. But if they are more stable, you think about your history, think about Socrates for pain is really important. And with associated symptoms, it's good to think about these here. So vomiting, seizures, have they noticed any neurological changes? So sensory losses, any trouble with their motor function in their legs, in their arms, in their face, any problems with the bladder or bowels, and then symptoms of meningism there as well, and obviously being febrile to think about infectious causes, and their level of alertness. Has their GCS dropped, and has there been any trauma recently, because that's also very important. So let's move on to some cases. I know that's what you guys all are wanting. So I've done a bit of talking. I'll let you guys do the talking. So we've got a 32-year-old man. He's coming into A&E. Let's say you're it's your first shift on the medical take. And he's somehow bypassed A&E, and you've been asked to see him, and he's been complaining of a headache. So as always, A to E approach, airway seems fine, his breathing also seems fine. We're not too worried about that. Circulation, what do we think about that, guys? What do you think about that blood pressure in a 32-year-old? Is that normal? Yeah. So Sonia said very hypertensive. Yeah, I guess it could be. It's on the and you, yeah, as a 32-year-old, you shouldn't have a blood pressure that high. But yeah, he's hypertensive, and that's not right. And his heart rate's 85, so which could be normal for him, but also could just be a low, just a minor sign that there's something not quite right going on. But other than that, his GCS is fine, his pupils are fine, and his temperature's fine. So he's got a headache. I think for your exposure, it's very reasonable to do a neurological exam. And actually, you don't find much in that. Okay, so what's the next important thing to do? So your A to E hasn't found much apart from a bit of hypertension. So what do we want to do now? So are we going straight to a scan? Also, some of you guys are messaging, just saying to hosts and panelists, just everyone just make sure you're putting it to everyone so we can all see. Don't worry about what you put in the chat. It really doesn't matter. I just want you guys to get your opinions out there. So would we jump straight to a scan? Have we done anything? We've just done an A to E. Are we going to scan this 32-year-old immediately just because he's got a bit of hypertension? If I rang the radiologist, what would they say to that? They'd probably want a little bit more information. And how are we going to get that? Yeah, fantastic. Okay. Sorry, I'm not teaching you to suck eggs here, but you know, it is true. History, examination, and then investigations. Okay. So history. So this young gentleman tells you that he was on the toilet and he was straining, and suddenly he got a very sudden headache, and it hasn't gone away, and that was about 3 hours ago, and he's vomited once, but doesn't really think there's much wrong. He just sort of wants some paracetamol to sort it out. Okay, what do we do now? Are we worried or not worried? Yeah, okay, good. You can take a bit more detailed history of the headache. Very good. Sorry, that was quite quick from me. It's so yeah, sudden onset, very sharp, really won't go away. Nothing makes it better, nothing makes it worse. He's got vomiting, one episode of vomiting, but no loss of consciousness, and he doesn't feel drowsy or confused or anything. And it happened when he was straining. What next? Are we worried? Yeah. Okay, I like that. It's a red flag. So as always, examination, but we've done a neurological examination. It didn't really reveal anything. So next, I think we should do some bloods and have a look and see. And they're actually fairly normal. So I haven't written them down here, but nothing untoward. Okay. So do we think this person, do you think we can safety net this person? Do we think we can just say, just watch and wait and admit him? Or do we think that we need to intervene? Anybody? Yeah, very good. Guys, honestly, feel free to put things in the chat. I really don't mind. I'm not going to judge anyone for any answers. Yeah, we need to intervene, okay? So let me go to the next slide. So, okay, he's vomited twice rather than once. This guy needs a CT scan, all right? Firstly, to rule out other causes, but also because we're probably going to need to do a further investigation for him. What do we think is going on? From that history, what's the most likely diagnosis, and what do we need to do? What intervention other than a CT scan does he need? Yeah, so the CT is to find if he's got raised intracranial pressure. Fantastic. But what's the diagnosis from the history? Fantastic, Nadia. Yeah. So it's a thunderclap headache. It's a really sharp, sudden onset, and it is a subarachnoid hemorrhage until proven otherwise. Okay. So this patient needs a lumbar puncture. All right. Now you'll get sick of these on the medical take because you'll get ones that are less severe than this and a bit hazier. And your consultant and your registrar will very much understandably and very reasonably do insist that a lumbar puncture is performed, and that often the reg will do it. And I think in about sort of 18 out of 20 cases, they tend to be negative. But, you know, it's important for those 2 out of 20, those 10% that you do them. So what are we doing a lumbar puncture for? What are we looking for in the cerebrospinal fluid? Yeah, so xanthochromia, fantastic. And that basically is the breakdown of red blood cells within the CSF. Okay. Now the first thing when you're doing an LP, and try and get involved in them when you become F1s, if you're a DGH or something where there's not too many people around, you know, try and badger your registrars to do them because they're good fun. You basically you collect the CSF and you can see, often you can see if it's red and you think, oh God. But the important thing is you need to differentiate between it being a traumatic tap and it being a subarachnoid hemorrhage, because traumatic tap is just the blood that's come from you putting a needle in them and you've gone through a blood vessel. Okay. And to do that, when you collect them off, you number the bottles 1 to 4 and you ask for red cells in bottles 1 and 3. And if there's a high red cell count in 1, but a lower red cell count in 3, it indicates a traumatic tap because the bleeding will reduce. If they're high in both, that indicates a subarachnoid hemorrhage, and they'll send it off for xanthochromia. But this test can take about 12 hours to come back, which is really frustrating, particularly if the patient's a bit unwell. So if you've got those red cell counts, that can be really useful. And this patient will need to be referred to a neurosurgical centre. So around the southeast, it tends to be King's or Brighton, because the likely precipitating factor is a ruptured aneurysm around the circle of Willis, often a berry aneurysm, which is associated with connective tissue disorders such as Marfan's. And that'll need to be coiled or clipped by the neurosurgeons. The other thing to mention is you can start them on anti-seizure medications. Yeah, very good point, Nadia. You are supposed to wait 12 hours before doing the LP, and that's because sorry, I didn't mention that. That's because the red cells won't have broken down in that time, so you won't have a reading for the xanthochromia until 12 hours. So if you're really worried and the history fits, get the referral in early, and yeah, so you can do anti-seizure medication if they are seizing. You can also consider giving something called nimodipine, which is a calcium channel blocker. It's very similar to nifedipine, and it prevents vasospasm of the arteries nearby, to essentially reduce blood flow within the vessel that contains the aneurysm. Okay, to lower the amount of bleeding. All right. And obviously don't give them any VTE prophylaxis and that sort of stuff. Okay, just put some TEDs on them. Cool. So that is subarachnoids. Case number 2. Any questions? Put them in the chat, guys. I'm more than happy to answer. 64-year-old man has come in with breathlessness earlier today. However, now the nurse rings you and says he's complaining of a headache. It's a bit strange. So you go and see him. His airway's fine. Breathing, he is sat to 90% on 4-litre nasal cannula. His respirator is 22 and a chest x-ray has not been done yet. He's got reduced breath sounds in the right lower lobe. Okay, so A to E, what are we doing with this guy? Yeah, fantastic. Let's get him on 15 liters. Let's get that oxygen saturation back up. We'll get an ABG to see how he's oxygenating. Is he, we don't know anything about him. He could be a smoker. He could be in type 2 respiratory failure with COPD. So it is important to get a gas. Very good. So you can take that, get someone to send it off, carry on with your assessment. C, you're pretty happy with actually. His cap refills 3, and luckily for you, the A&E nurse put a cannula in for him. So I'd probably just start him on some fluids. Just slow bag because he's hemodynamically stable, but he probably appears a bit dry. Maybe he's got dry mucous membranes. Fine. D, not worried. He's alert. He's everything's normal. He's afebrile. His pupils are normal. He just seems quite out of puff to you, and he's got this headache. And so you wondered, you need to do a neurological exam on this man. Pearl means pupils equal and reactive to light. And I think this man probably does warrant a neurological exam, okay? Because, well, what would lead me to think that is taking a better history, okay? So Socrates, finding out a bit more. And he tells you that he has had headaches on and off for the last few weeks. And his breathing's been getting worse. And actually, he's previously vomited a couple of times. And he says the headaches are quite bad at night as well. And when he lies down, they're really bad. Okay. But it's better when he sits up. So he's found himself sleeping upright at night. So do we think we need to do a neurological exam for him? Yeah. What are we worried about? Anyone got any idea? Anyone think what might be going on with this man? Just throw out suggestions. There's probably a few things that could be going on. Yeah. Very good. Sleep apnea. Yeah. Particularly with the sleep. Quite often they don't like lying down, and the hypoxia can cause headaches, and the retention can also cause headaches, which would obviously be worse at night. Very good, but can get them in the day. True. Sinusitis, yeah, fair enough. On and off. What if I was to tell you that he looks a bit thin and he looks a bit gaunt? Could I repeat the history again? Yeah. Sorry, Nadia. So he's headaches on and off, worse at night, worse when lying flat. Had a bit of vomiting recently. And yeah, he thinks he's lost a bit of weight. He thinks he's gone down a belt size or two, and his breathing's getting gradually worse as well. Yeah, and malignancy. Okay, I think this is the big red flag for me. And always ask. I deliberately didn't put weight loss in there because I think it always gives it away in a multiple choice question or in a case. But that's what would really concern me. So the first thing I would get is a chest X-ray for this man. Okay, and you go and he's got a large right-sided unilateral effusion. Okay, and 70% of unilateral effusions, unilateral pleural effusions, are malignant. Okay, so if you see an effusion in one side of the lung, you need to be worried. Okay, that is a concern, and it probably would need to be tapped off at a later date and sent for cytology, and it would most likely be blood stained. But in the interim, this headache sounds a bit strange, and the big red flag for me is it's worse when he lies flat, because that implies raised intracranial pressure. All right. Because when you lie flat, you get more blood in your brain, and that indicates from the Monroe-Kelly doctrine that and that's why it causes a headache, and that's why you get raised intracranial pressure. Everyone know the Monroe-Kelly doctrine, in that you've got basically 3 things inside your skull: blood, CSF, and brain tissue. And if you get an increase in any of those 3, it leads to raised intracranial pressure. So yeah, I think we're worried about brain mets. This guy needs a CT head, pretty sharpish. And this is what his, oh no, I haven't done it yet. It's on the next slide, sorry. We've gone through that, fine. So this is what his CT head shows. And as you've correctly pointed out, he's got quite widespread metastatic disease in the brain, unfortunately. And this is the cause for his headache. Now, what is the treatment for this? What is the urgent treatment for this man? Yes, fantastic. Yeah, he needs dexamethasone IV. Probably, I don't know the exact doses, but I think it's either 8 or 16 milligrams, and then he'll need to be continued on dex. When he's on it regularly, try not to give it at night, because you can get people can go pretty loopy with steroids. Make sure their BMs are monitored, and make sure he's on a PPI as well. Okay. And then obviously escalate this. Someone needs to know about it. In fact, I'd have discussed it well before getting a CT. It just sounds a bit strange. Okay. But yeah, very good. Case 3, probably quite a quick one, actually. So 56-year-old woman on the general medical ward. Let's say she's got, she's there because, let's see. She's come into the acute medical ward because her knee's puffed up and she can't walk anymore. And she's now complaining of a headache. So you go and see her, A to E, airway's fine, breathing's fine, circulation also fine. Okay, so she is a stable patient. That's fine. Okay, you go through your disability, as you can see there, and that's fine as well. She's she's very much with it. GCS is 15, BM's fine, afebrile, pupils also fine. You do a neurological examination. And the upper limbs you think are completely normal. Reflexes are normal, good power, normal tone, sensation is fine, and coordination too. Cranial nerves you do is fine, but there's just a bit of pain when you're examining the facial nerve. Okay, so on movements of the face in particular, that's a bit sore. But other than that, you haven't really picked anything up. So that, as we discussed before, I think now we move on to do a bit of history and find out what this pain is like. And she says she's been getting this pain recently. Sorry, no, she hasn't. This pain came on a few hours ago, she says, and it started slow, and now it's getting more and more severe. And it's on one side of the face. It's this side of the face, and it's a really sharp pain, and it's she says it's agony. She's had no other real symptoms, that no obvious things, no vomiting, she's not dropped to consciousness level. Okay, she's afebrile. Any other questions? So think about a unilateral headache. Now, what do we want to know more in the history that might tease us into a diagnosis? Very good, watery eyes. So she doesn't, but that would make you think about a cluster headache. Fantastic. Any others? Yeah, photophobia, very good. She doesn't have photophobia, but and actually doesn't have any visual changes either. Okay. Fantastic. Very, very good. So yeah, jaw claudication. So she says, yeah, actually, when she eats, or when she's moving her mouth or she's drinking water, she gets real pain, and it's like an ischemic. It's a sharp pain in the side of the jaw. Okay. Fine. So we've got that from the history. What in the examination we've done, a neurological examination, and just found a bit of pain on moving the face. What else would you like to do in your examination? Yeah, cranial nerve. So we've done a cranial nerve exam, and that's all you found, just a bit of pain on moving when she's chewing. Can anyone think it's linked into the jaw claudication finding from the history? I feel like it's just one person commenting, guys. Anyone else, please? feel free to chip in. I will obviously tell you the answers, but it's you know, it's better for you guys to try and think for yourselves. So the question was, you found that they've got a headache and jaw claudication. What from the examination do you want to do? Okay. And the answer is you want to just palpate around the temporal area, because they'll often have tenderness around there, okay? Scalp tenderness, and they may complain that when they brush their hair, they get pain. That's classic. It's classic in med school exams, but obviously you don't ever, no one ever comes in saying that. They might do to a GP practice, but yeah, if you press and you palpate, it's very tender along where the temporal artery runs. So what's the diagnosis? Excellent. Yeah, giant cell arteritis or temporal arteritis. So this patient needs some steroids. They need prednisolone very, very quickly. Okay. Why do they need it quickly? What's the risk if we don't get it to them in a couple of hours? Blindness. Yeah, they can lose the vision in their eye. So it's really important that you treat them, and it's high dose steroids. Okay. And then you can do a temporal artery biopsy as well, but the problem with that, you can get skip lesions, so you can't actually get the diagnosis from it. So yeah, that's just GCA, which is it's typically a stable patient, but that's why your history is so important after your A to E, because it leads you down the right path. And if you hadn't got that, we'd have had this patient who's got a headache and GCA and could have subsequently got blind if it had been missed. Okay, so very important. Okay, last case today, guys. You're doing very well. So this is a nice fun one. 17-year-old man comes to A&E. He's drowsy and he's got a headache. Uh-oh, I hope alarm bells are ringing in everybody's heads. So airway's fine. Breathing, his SATs are a little bit low, 93, which in a 17-year-old man is not good. Respirates up a little bit, but his chest sounds clear. So you chuck him on a bit of oxygen just to help him along. But we don't think that there's any particular respiratory cause that might be causing this. Circulation, his blood pressure is 83/52, and he has a heart rate of 123. His cap refill time is 4, but his heart sounds are normal. He's cool peripherally. Okay. What do we do? What do we do straight away? There's a few things we can do. So I would get 2 large wide bore cannulas in, get fluid boluses. He's 17. He'll be able to take it. Get 500 mils in straight away. See if that picks his blood pressure up, or at least helps the heart rate. And then more and more fluids he needs. He's clearly very dry, whatever the cause is. At this point as well, actually, I'd probably go on to D. So while the fluid's running, you then get a BM, it's 4. His GCS is 13. So this is a man who is confused and he's not alert. He's only responsive to voice. And he's got a temperature of 38.2. And he said he's coming with, or his friends say he's coming with a headache. So at that point there, you're probably, having put the cannulas in and stuff, you're probably about 10 minutes into your assessment. That, I think I would probably call, at least call the med reg, if not put a peri-arrest call out, okay? Because this is really, really concerning, all right? Anyone got any ideas about what the diagnosis is likely to be, or what we're really worried about that we need to rule out? Yeah, good. Encephalitis along those lines. Again, could well be encephalitis. I'm not saying it won't be. Meningitis, yeah. So in a 17-year-old who's this unwell, it's probably going to be meningitis. That's the most likely cause. All right. So what do we do? Meningitis is an infection. So what do we need to do? It's sort of part of the A to E, and everyone bangs on about it. This is an unstable patient with an infection on board. What's the buzzword I'm looking for, and what do we need to do? Yeah, sepsis. And with sepsis, our management comes the sepsis 6. So we are going to take 3 things. We're going to take a lactate, so get a gas off straight away. His lactate's going to be high, okay? We're going to put a catheter in and take a urine output, okay? And then also when we put the catheter in, the cannula in, we're going to take bloods, and in those bloods is going to be blood cultures. That's very, very important, okay? And then he's 17, you should be able to get a cannula in fine. So the antibiotics shouldn't need to wait. With this man, we need to get broad spectrum antibiotics in very early on, okay, as soon as you can. We also need to give him oxygen, which we're doing, and we need to give him fluids, which we're doing. The antibiotics, any idea what antibiotic we would give him, or what class of antibiotics? Yeah, fantastic. So we'd give Kef, and ceftriaxone is the 3rd generation cephalosporin that we would probably give. 2 grams IV stat, and basically hope that helps, because if you delay that, he's going to get worse. And the trust I worked at last, there was a patient before I got there, an A&E came in with a bit of a mild headache, but seemed fine, had a bit of a low-grade fever, but was otherwise completely normal. Obs were fine, just took some paracetamol, which slightly improved it. So they discharged him, safety netted well. He went home on his own. I think his mum came back a few hours later and he'd passed away. He had meningitis. It is that quick, it's that scary. So we haven't gone on to E. We've done our sepsis 6. What in E, what would we look for? So do a neurological exam, I'd recommend, definitely, to see, partly to see if there is any neurology, but also it's really useful at a later date to have a neurological exam formally documented in case anything changes. And you can say that, you know, there's a clear change in their focal neurology. But also have a look all over their body, you know, look at everywhere, okay? Arms, torso, back, buttocks, thighs, legs, feet. You're looking for a rash, okay? Because that will indicate meningococcus, and that'll be a meningococcal septicemia. And you get a rash because essentially you've got an infection source that is throwing off little microemboli of infection, of vegetation, and those can block off capillaries and arterioles, and subsequently result in bleeding that leads to a rash. Okay, that's the actual pathophysiology of it. So reassess him as always, see how he's doing with the fluids, see how the antibiotics are, keep a really close eye on him. He needs to go to an HDU setting, absolutely. Get a CT head on him to check that he's not got any raised intracranial pressure. Sepsis 6 we've done. And then this man needs an LP. Now, in this case, the LP should be done after antibiotics, okay? Because this is a man that's very, very unwell and could deteriorate very quickly. If it was a less obvious one and there was maybe a low-grade fever and you're a bit unsure and it could be like a viral meningitis, then the antibiotics can wait till after an LP, and you can get the white cell count and the glucose back, and that can give you an idea. And if there's a neutrophilia, then you might start antibiotics, or if there's raised lymphocytes and a normal glucose, you can think about starting acyclovir for a viral infection. Okay, and often in practice, clinicians will just start both on ceftriaxone and acyclovir to cover, and that's very reasonable too, because it's a very scary condition that can cause serious harm. And on the right there, I've just put the main organisms that cause meningitis. So the top 3 are bacterial meningitis. So in adults, it tends to be streptococcal pneumoniae. In teens, it tends to be Neisseria meningitidis, which is that's what would cause a meningococcal rash. And in infants, you often get a Haemophilus influenzae following a sort of mild respiratory illness. but can also be E. coli and Klebsiella. Immunocompromised tends to be more fungal. So Cryptococcus is the classic example in the textbooks. Also, you can get TB, particularly in immunocompromised, and viral pathogens as well, which tend to cause a less severe type of meningitis, but still one to be very aware of, because patients can get very sick. So that is everything. I hope that was helpful. Pop any questions in the chat if that's helpful, guys. I hope it was useful. Please give feedback to myself and also to the biomedicine team. It's really useful. Hopefully I'm adapting